to talk to you on this topic. So friends, let us directly go to the topic. Uh, okay, we are talking about a very specific topic, beta blockers in cardiac failure. Okay, now friends, we know that of course cardiac failure is a really dreaded condition. We know that basically it's a pathophysiological state where heart is not doing enough as per the needs of the body, isn't it? And if it does, it does with elevated filling pressure, that is with congestion. So raised venous pressures, pulmonary edema, and then the output is okay. So that is the definition of cardiac failure. And we know, friends, that this heart failure, it has been discussed since long time. Now, this great man, Sir Thomas Lewis, in 1933 had said that the very essence of cardiovascular medicine is the recognition of early heart failure. That means it was that important that he had thought that, heart failure is so important. Early recognition will give good results. Okay. Now this has become so widespread, friends, that it is 1 to 2% of the general population in the adults, and over the age of 70 years, it's 10% of all people. Okay, and at a time maybe in USA, about 58 lakh people have got cardiac failure, and almost 2.3 crores all over the world. Friends, we say heart failure, but these are actually, there are 4 stages which are recognized of heart failure. Now, why these are important is so that we can treat early. Now, stage A is something where there are risk factors for heart failure, but actually the patient has not yet developed any structural heart disease. Stage B is something which is okay. Patient has got structural heart disease, but has not yet developed symptoms of heart failure. Okay. So that is how from one stage the patient has gone to the second stage. Stage C is the one which we really clinically call as cardiac failure. Okay. So these are the patients, they have got structural heart disease and they have got heart failure symptoms and signs either now or they earlier had and they already taken treatment. So that is stage C. And stage D is something where they are refractory to usual treatment and then they require some advanced treatment. Maybe hospitalization, intravenous inotropes, maybe some device therapy, maybe intra-aortic balloon pump, or maybe ultimately surgery and so on. So they are all stage D. Now, why this is important is because the prognosis changes. Okay, as we were discussing, well, the prevalence is very high and mortality is very high also. That comes to about 1 in all 9 deaths can be because of the heart failure. And in USA, every year, 55,000 people die of heart failure. Now, after the diagnosis of heart failure, in the first itself, about 38% would die. And by 5 years, okay. Now, this stage is, as I told you, A, B, C, D. Now, as we go from stage A to B to C to D, the mortality is higher and higher. Okay, right. And you see that heart failure related to mortality is so important that about the 60-year-old man who is a non-diabetic. Okay. Now, what are the chances that he will live for how many years? If he has no disease at all, then on an average, this person is likely to live for 20 more years. Whereas this will drop down to only 4 years if the patient is already having cardiac failure. The other diseases, of course, coronary artery disease, acute MI, stroke also reduce the outcome. But certainly if the patient has got cardiac failure, then expected survival goes down to very low levels. Okay. And every year after diagnosis of heart failure, the mortality goes on increasing. See, so for example, in hospital mortality all over the world is considered as about 10%. Now, in 30 days, it jumps to 14%. And 3 months, it has already gone near 20%. By 1 year, 32%. And as we were discussing, it goes on increasing. And by 5 years, 50% will be dead. Okay. Now, because of this, friends, the large prevalence, every year new cases, more and more cases. Mortality is very high. So many people require hospitalization. And even as outpatients, we had to see so many. Overall cost becomes very, very high of the burden of this heart failure. So it's a common condition. It's a very costly and it's a deadly condition. So early diagnosis, prevention, risk stratification, monitoring, and managing heart failure is very, very important. And of course, recently we know we have been using biomarkers also like BNP, pro-BNP, etc., etc. Now, is it we are talking about the world figures? What is the situation in our country? Okay, it's a major health problem in our country as well. Okay, and after admission to hospital with heart failure, mortality in our country is much more, 20 to 30%. Now, our patients, unfortunately, their adherence to medicines is very low, 25 to 50% only. And, like there is guideline-based medical therapy, which is optimal. So adherence to this and tolerance to these medications is low in our patients. Similarly, age of presentation with heart failure in our country, now 3 Indian studies have said that the age of presentation may be around say 61, 58, 56. So say around 60, less than 60 also. When compared to the Western figures, it is 72 years at which the people present. So our patients are younger when they present with heart failure. Okay, prevalence is also high in adults, 1% of adults, so that will become a large number, 80 lakhs to a crore of patients. And mortality is very high every year. Prevalence of the risk factors are a little different from the Western population. And for example, in our patient, diabetes is much more common than the Western numbers. And the prognosis of heart failure in our patients, therefore, is much worse. Now, after hospitalization, we are talking about Indian patient with heart failure. After one discharge, if the patient requires more than one readmission again in 1 year, the mortality suddenly jumps. Whereas the patient doesn't require another hospitalization, the mortality is lower when compared to people requiring repeated hospitalization. So 1 year mortality rate significantly is higher if the patients require more than one hospitalization, and that, that becomes almost 3 times. Okay. Now, as I was discussing, guideline-directed medical treatment is really not optimal with our patients. Now, what we see is, well, if you see what the patients say, 94% are receiving some drugs, which is this diuretics. Now, certainly diuretics, because when the patient comes in cardiac failure, he comes to you with symptoms, maybe breathlessness, symptoms of congestion, edema, and so on. And so certainly they do take diuretics so that they do get symptomatic relief. So many patients are taking diuretics. But if you see the disease-modifying drugs, for example, ACE inhibitors, ARBs, okay, aldosterone receptor antagonists like spironolactone or eplerenone, and therefore overall optimal treatment is received only by 19%. So it is so sad, and that may be one of the reasons why outcome in our patients is not good. And now with every hospitalization that the patient requires, see, his cardiac function goes down further. So heart failure, we can never really call it stable, because gradually, it doesn't remain stable like this. It is gradually downhill course. And because of that, we have to act very quickly. So treat very early so that the patient doesn't have to go down like this, and the outcome should be better. Now, heart failure, of course, we initially called it only heart failure, etc. But now we know that now heart failure, according to the ejection fraction, can be classified as heart failure with reduced ejection fraction, which is our earlier understanding of heart failure. But there are heart failure patients where ejection fraction is preserved, and preserved is more than 40%, but now it is considered as more than 50%. So more than 50%, and still they have symptoms and signs of cardiac failure. That is heart failure with preserved ejection fraction. And when it is less than 40%, it is heart failure with reduced ejection fraction. And the range in between 40 and 50 is considered as heart failure with mid-range ejection fraction. Now, why is this important? Day by day, friends, all over the world, what is seen is more and more patients presenting to you with heart failure have got heart failure with preserved ejection fraction. So if you see in the hospital admitted patients for heart failure and their ejection fractions, now gradually we see more and more number of patients who have got ejection fractions over 50%. And therefore it is said that the real threat to the health is not only global warming and some infections, etc., obesity, because obesity we know is one of the very, very important precipitating factors for heart failure with preserved ejection fraction. Okay, heart failure with preserved ejection fraction, friends, atrial fibrillation is more common. Now, this particular diagram shows that number of patients having atrial fibrillation at the time of diagnosis of heart failure. This is at the time of diagnosis of heart failure. So many are having hypertension, whereas many of them had earlier atrial fibrillation and some of them develop it later. So in short, two-thirds of all patients of heart failure to preserve ejection fraction have at some time got atrial fibrillation, or if they did not so far have, they'll develop it. And you know why that is important is because again with atrial fibrillation, exercise capacity of the patient goes down and mortality rises. So that is how atrial fibrillation becomes very important. So diagnosis of heart failure with preserved ejection fraction is very important. You can use the simple scoring system here because these are the precipitating factor, that is body weight. Obese people certainly have got it more, so you give 2 points. Similarly, hypertension, atrial fibrillation, pulmonary hypertension, age over 60, and increased left ventricular filling pressures, that is endostolic pressure. Now they all have to be given points. And as the score rises, the gradually chances of diagnosis of heart failure preserved ejection fraction go up. So when the score is 7 or above, certainly it is heart failure preserved ejection fraction. But the probability goes on increasing as the score goes about 3, above 4. Okay, now coming to this, our topic. What is the role of beta blocker in heart failure? Friends, beta blockers, now we know that, beta blockers came so long ago. Now, this Scottish physician and pharmacologist, James White Black, in 1962, he discovered propranolol. Okay, and of course, cimetidine also. And now for this discovery of his, he was given Nobel Prize in 1988. So beta blockers date to that, 1962. And thereafter, we know so many other beta blockers came. Propranolol, then came metoprolol, nadolol, and so on, so on. Right now, in the present century, nebivolol also have come. So many beta blockers have come. Some of them are cardioselective, some are non-selective, and some have additional vasodilating property like carvedilol and nebivolol here. Okay. Right, we know beta blocker has got so many effects. That is, beta receptors, when they are activated, there are so many effects. It's on SA node, so increase in the heart rate, AV node, atria ventricle, increasing contractility. On the vessels, it is vasodilatation. On the bronchi, it is bronchodilation. That is the effect of stimulation of beta. And when you are going to block beta, these effects are going to be negated. Now, this was early study of beta blocker in cardiac failure. People have thought of that beta blockers can be effective in cardiac failure. But see, look at this early study. This came in 1966. Extremely small study, only 3 cases. What was done was full dose, 75 milligrams of then beta blocker available, pronesol, thanol. 75 milligrams IV was given. And what happened was there was dramatic worsening. Actually, patient worsened. So this and similar case studies gave a conclusion, that patients in heart failure or with incipient heart failure, actually that can be disaster. And therefore, in these experiences, because of these experiences, beta blockers, they were strictly contraindicated in cardiac failure, and that continued for about 30 years. That means until 90s, beta blockers were considered as strictly contraindicated. Now here I must tell you something. 1975 study came. Okay. Now they started beta blockers then available at a lower dose, and then they gradually went up and continued for 2 months to 1 year. And then they found was, what was found was that physical capacity was increased, heart size reduced. This was done by non-invasive investigations which were available that time. Please remember, by then echocardiography was not freely available, but it had started coming. Okay, and then the conclusion was that beta blockers can improve heart function, at least in some patients with congestive cardiomyopathy. That was the conclusion. See, this was the study by Wachstein in 1975. Now, this study came, but again, beta blockers continued to be contraindicated. Here, I must tell you something. Many of you may be knowing him, Dr. B.K. Goyal. In 1978, I joined JJ Hospital as junior houseman in cardiology department under his care. And what I found was, to some patients of heart failure, we had discharged them. And when they came for follow-up, I found that Dr. Goyal had started beta blocker. And then because at that age, you are, of that mind that how come this contraindicated drugs is started by the boss? And I used to argue with him and stop the drug. And he used to tell me that theoretically they're contraindicated, okay, but we must try in some patients because I have seen clinical improvement in these patients. Friends, I'm ashamed that actually I didn't do anything like that. Otherwise, we could have been, one of the first to be credited for beta blockers in cardiac failure. I didn't do anything like that. And then the further studies came. What happened was ultimately we saw 180 degrees change in the treatment. The drugs which were totally contraindicated became the first line treatment. We know the effects of beta blockers, what they do. On beta 1, heart rate comes down, contractility comes down, conduction is decreased. With beta 2, other effects are there. But again, there is vasodilatory, some are vasodilatory and so on, third generation. So these are the effects. At the same time, what they also do is they inhibit also renin-angiotensin system. Now that also is important. Now, therefore, the new thinking came in pathophysiology of heart failure that it's a state with high catecholamine levels. Now, the high catecholamine levels are initially useful as cardiac drive. However, if they continue to be there, then in long term, they become detrimental. So what that causes is myocardial apoptosis, that is cell death, fibrosis, and remodeling, which will worsen the heart function. And therefore, this formed the pharmacological basis for beta blockers in heart failure, that these beta blockers will cut down these bad effects of catecholamine-driven detrimental changes. And what was expected to the beta blockers to do? Upregulation of beta receptors. So now thereafter, once he had treated with beta blocker, then the beta receptors will become more responsive to beta adrenergic signaling. Heart rate will come down, which will increase the coronary flow and decrease oxygen demand. Protection from myocyte toxicity, which is caused by catecholamines. Ventricular arrhythmias will go down. Apoptosis will reduce, and renin-angiotensin system will be inhibited. So these would be the effects of beta blockers. And in cardiac failure, friends, cardiac contractility wherein it is going down, peripheral perfusion is going down, and then we see sympathetic activation comes, and that causes this apoptosis, necrosis, fibrosis, hypertrophy. This will be blocked by beta blockers, and therefore cardiac remodeling will be prevented and long-term cardiac contractility will be preserved. So this is the basis for beta blockers in heart failure. Similarly, then why earlier studies had failed and new studies showed some changes? In 1990s, what changed? What was done so that the contraindication became an indication? What was done by the newer studies in 90s is starting dose was lower than the other medicine, other indications like for hypertension and for angina, much higher doses were used. So slowly they were up titrated and accepting that some patients may require the lower doses only. So the dose will depend on the patient's individual tolerance. That was accepted by these studies, and therefore we found that initially the drug which was used for hypertension, that is beta blocker, was used initially for hypertension and angina. Those indications initially were high, but gradually those indications are now coming down, we know. But later studies, we started coming in for heart failure and post-myocardial infarction. And that indication and the use of beta blocker is now going up, as we know. Okay. Now, so many studies came. Friends, in treatment of heart failure, ACE inhibitors, ARB studies came much earlier and they established themselves. So captopril studies came and so many other studies, captopril, enalapril, all those studies came. And then they were establishing themselves in the treatment of cardiac failure much earlier, much before beta blockers. In 75, etc., they were established in treatment of heart failure. But after several years, when they remained contraindicated, beta blockers after 90s, the studies which came in 90s with metoprolol, bisoprolol, carvedilol, and so on, and ultimately nebivolol, that studies came later on, and then they showed improvement, and therefore they have become first-line treatment in cardiac failure. Friends, we know whatever reduces mortality, whatever therapy reduces mortality in heart failure, we must use. And these are the therapies which have now been proved. For example, ACE inhibitor ARBs. Now, ARNI we know, beta blockers, mineralocorticoid receptor antagonists, that is spironolactone and eplerenone, combination of hydralazine and nitrate, and where required, the devices. So, defibrillator, implantable defibrillator, biventricular pacemaker. Now, SGLT2 inhibitors, also we know, we should remember now, recently they are coming in the treatment of heart failure. In fact, the use is now getting extended even to non-diabetic people. And in certain patients where there is severe mitral regurgitation in cardiac failure, procedure like mitral clip also can reduce mortality to large extent. So in our patients of heart failure, we had to ask ourselves what best treatment I can give to my patient. And then in combination, we should try and give the best treatment to our patients. So sacubitril and valsartan, so that is ARNI, it works in the heart failure by working on renin-angiotensin system as well as natriuretic peptide system. Sympathetic nervous system beta blockers would work better. And friends, therefore, we must try and use ARNI, then MRAs and beta blockers in patients as much as possible to get good outcomes. Now, beta blockers do additional things. They bring down the heart rate, we know. And what has been proved since long time, especially in myocardial infarction, is if you can reduce the heart rate by 10 beats per minute, mortality can come down by 26%. And this has been shown since several years. Now, this was the study in 2006. Okay. Now, the basis there discussed was that when a donkey is tired, like save its energy and don't allow it to run, limit the speed so that it can work better. Friends, when we are talking about heart failure, okay, and we are talking about various forms of cardiac failure, left ventricular ejection fraction, various numbers. So this last study, which was presented in European Society of Cardiology Congress in 2017, beta blockers in heart failure collaborative group. Now, what is that collaborative group? There are so many individuals from all over the world who are part of that. And what did they do? They did a meta-analysis of so many studies of beta blockers. And they were looking at heart failure with reduced ejection fraction and heart failure with preserved ejection fraction and how beta blockers are helpful. And what did they find? They were looking at this. What is the effect of beta blockers across the spectrum, that is ejection fraction below 40, mid-range 40 to 50, and above 50. Okay. And what was seen was, unfortunately, for this particular group, mid-range and preserved ejection fraction, by themselves, there are no good randomized controlled studies for this particular group. And therefore, what was seen was good effects were always seen here. And therefore, this particular study was looking at what happens to these patients also. And they were also looking at what happens with age, because whether with various age groups, whether the effects are different. And what was seen was, of course, in younger age, people in their 40s and all, the effect will be much better. Whereas in older people, though effect may not be as pronounced as in younger individuals, beta blockers are still useful and the risk will be certainly reduced. Okay. Now in sinus rhythm, these three groups, ejection fraction below 40, 40 to 49, and above 50. What was seen was in the low ejection fractions and mid-range ejection fraction, certainly the mortality is reduced, whereas mortality was not found to be affected much if the patient was in sinus rhythm and ejection fraction was more than 50%. What about atrial fibrillation? Whether it makes any change, sinus rhythm, ejection fraction can increase so much in all the patients. Okay. Whereas in atrial fibrillation also, of course, please look at this. If baseline ejection fraction was more than 50%, whether in sinus rhythm or in atrial fibrillation, ejection fraction doesn't go further with beta blockers. In fact, here it was shown that it can come down marginally. Marginally, if it is sinus rhythm, if it is atrial fibrillation, that drop may be a little more. Okay. But in sinus rhythm and low ejection fractions and mid-range ejection fraction, certainly ejection fraction can improve. Similarly, they were looking at all-cause mortality in sinus rhythm and all-cause mortality in atrial fibrillation. It was seen that in sinus rhythm, it was certainly mortality was reduced remarkably by beta blockers, whereas in atrial fibrillation, they showed that there was not much of a difference in all-cause mortality. Okay, so their summary was outcomes, what beta blockers, they certainly improve ejection fraction and reduce cardiac mortality if in sinus rhythm and ejection fraction which is low or mid-range. They have accepted that there are too few studies and too few patients to comment anything about good ejection fraction, more than 50%. And in atrial fibrillation, when we don't see mortality, though we see better improvement in ejection fractions, but mortality benefits are not there. So that therefore it is said that there is consistent evidence is not there, but further investigation should be done. So friends, in short, see, when we are trying, all of us are treating, all over the world, people are treating heart patients to reduce mortality and morbidity. Now, long back in 94, initially when the statins were not there, and statins came, simvastatin was first, the study was done, and what was seen was that in this high CV risk patients who were either diabetic, some hypertensive, if you treated 30 patients with simvastatin, you would save one patient. Now, further we come, okay, statins were already there. Now, ACE inhibitors, ARBs were not there. And the studies started coming with ACE inhibitor, ARB. And what was seen was these patients, now more number of patients are diabetic and more are hypertensive. The group is changing. With ramipril, over 5 years, you would have to treat 56 individuals to save one life. And with this continued, now recently, now what we are seeing is people are using ACE inhibitors, ARB or ARNI, and they are already on statin. Now to reduce mortality further, metoprolol study showed that you had to treat only 21 patients over 3 years to save one life. So that is how, friends, these drugs are changing the outcomes. Beta blockers, friends, certainly you should use in heart failure, certainly post-MI patients, and ventricular arrhythmias post-MI, certainly you should use. You may use in other arrhythmias, which are not ventricular arrhythmias, maybe atrial fibrillation. Acute coronary syndrome, which is non-ST elevation MI, you may use it. Then acute phase MI, you may use it. Okay, stable angina without MI also you may use. Hypertension, selected patients, not all we know, where we know, because earlier there were class 1, but in now class 1, now beta blockers are not there. Okay, and in metabolic syndrome, we have to be a little careful. Which beta blockers? Well, now propranolol, metoprolol, timolol, acebutolol, carvedilol, nebivolol, bisoprolol. Now, of course, we use bisoprolol, nebivolol, carvedilol, and metoprolol mainly, isn't it? Now, mainly, you can use them in all our indications: myocardial infarction, ischemic heart without MI, heart failure, and so on. So, indications are extending, and we should be able to use in almost all patients. Now, this is, friends, another study where they wanted to see, what happens with age and gender. Okay, this study was also presented in European Society of Cardiology, and they were looking of all-cause mortality and heart failure hospitalization whether age and gender come into play for outcomes of heart failure with beta blocker. Now, why this study was done? They say background was what? That we know that, okay, in reduced ejection fraction, heart failure, it is class 1A recommendation, okay. And in atrial fibrillation, okay, perhaps we have not really got evidence for reduced mortality. Now, there are some concerns with women and some concerns with elderly. And therefore, in fact, if we are not getting benefits and if we continue to give, then there will be a problem with tolerability of beta blockers. So therefore, this study was done. And what did they find? All-cause mortality and beta blockers according to age, whether the age group was below 50, below 60, below 68 or below 75, all the age groups benefited by beta blocker therapy. Similarly, in women, it was seen that all-cause mortality as well as heart failure hospitalization, they come down as much as in men. And so therefore, this is not a concern that was seen by this study. So our analysis confirms that beta blocker reduce mortality and heart failure related hospitalization, okay, in especially with reduced ejection fraction patients in sinus rhythm, irrespective of age and gender. So absolute effect sizes were similar across all age groups and also both genders. And so therefore it should be used. Okay, friends, so we are using so many therapies. If you use beta blockers alone, of course, mortality can be reduced significantly. But if we use combination of ARNI, beta blocker and MRAs, mortality can be reduced to a very large extent. So wherever possible, we should try and give, when tolerated, when there is no other contraindication, we should give these patients the best possible therapy. So beta blockers, friends, in guidelines, whether we are talking of European or American, certainly ST elevation, MI and ejection fraction below 40% on heart failure, certainly class 1A indication. Non-ST elevation, MI with ejection fraction below 40 and heart failure, also 1A indication. Okay, if ejection fraction is above 40, that is mid-range or normal ejection fraction, well, you may give according to European guidelines. American guidelines would say, yes, you should give. Okay. And if it is non-ST elevation MI, ejection fraction is mid-range or normal and heart failure. Okay. European Society doesn't mention anything about it, but American Cardiological Society says that, yes, you may use, that's the expert opinion. So stage B failure, friends, where structural heart disease is there, for example, myocardial infarction, no symptoms and signs of heart failure in all patients with recent or remote history of MI or acute coronary syndrome and reduced ejection fraction, evidence-based beta blockers should be used. Similarly, okay, these patients who have not got symptomatic failure, but they have got structural heart disease, okay, and these patients should be given beta blockers. Stage C, of course, there are patients who have got symptoms and signs of cardiac failure and reduced ejection fractions. We know that one of the 3 beta blockers which has been proved by studies, bisoprolol, carvedilol, and metoprolol, should be used. It has to be given. Stage C, again, heart failure, preserve ejection fraction. Okay, beta blockers, we say that we may use, they may be beneficial, though it doesn't become class 1 indication. It is, you may give this and it is likely to benefit. Okay, but you can use beta blockers, ACE inhibitors or ARBs. It is reasonable to use. That's the expert opinion. When it is C, it is expert opinion. Okay, and of course, beta blockers should be continued even during hospitalization in the patients who have got cardiac failure, reduced ejection fraction. Okay, and after, when should you do it? Now, beta blockers initially, when the patient gets admitted with uncontrolled cardiac failure, once you can stop intravenous diuretics and vasodilators and inotropic agents, beta blockers can be initiated. Of course, patients who required inotropic agents, you have to be a little careful with beta blockers because you were giving some drugs which will increase contractility, and now you are going to use something which is going to reduce contractility. So you have to be a little careful. Indian guidelines in heart failure say that, okay, when you are treating cardiac failure, certainly ACE inhibitor ARB you should give. Beta blockers should be given to maximum doses gradually. Okay, then they, of course, this is in short, whatever they say about the treatment of heart failure. Then mineralocorticoid receptor blockers, they say, okay, ARNI instead of ACE inhibitors, what they say. But presently, friends, we know we are not discussing ARNI today, but ARNI can be initiated not after ACE inhibitors, ARBs. You can start them as the first line drug also. If with all this, patients are still symptomatic, then comes the role of digoxin. In 1978, when I was houseman, we didn't have any other drug but digoxin and diuretic. But now that has gone down. That is, after all these drugs, if the patient still requires, then we go to digoxin. And then we consider other devices like CRT and so on. So heart failure reduced ejection fraction, Indian Heart Journal study, it says that you should give these drugs. Okay, in short here, the beneficial drugs, ACE inhibitor, ARNI, beta blockers, MRAs, diuretics, and when required, in addition to beta blocker or when we can't give beta blocker, the ivabradine. Other drugs we may use like digoxin when this is not sufficient, digoxin, etc. But of course, iron supplement, when especially iron levels are low, that should be used. We are not very sure of use of metabolically active drugs like trimetazidine, carnitine, and so on. Okay, and some drugs can be harmful, so should not be used in uncontrolled cardiac failure, especially like glitazones for diabetes and non-steroidal anti-inflammatory drugs and diltiazem verapamil, who have got only negative inotropic effect. They should not be used. So, friends, pharmacological treatment, which is certainly indicated in almost all patients of symptomatic heart failure, is ACE inhibitor ARB, beta blocker, and MRA, class 1A, so must be given. So almost all the guidelines, whichever guidelines you talk of, right from 2012 to 2017, they all say ACE inhibitor beta blockers in all patients with ejection fraction below 40%. I am saying this again and again because it is extremely important. Friends, ACE inhibitors, ARBs, beta blockers, mineralocorticoids by themselves certainly reduced mortality in heart failure. But what about their combination? See, if ACE inhibitor is given, mortality comes down to some level certainly. But if you add beta blocker, then it can come down further. And if you add MRA to that, mortality can come down really further. So therefore, we should give best to our patients. Now, these studies, beta blocker, all the 4 beta blockers that we have been using, they have all shown that there are mortality benefits and heart failure hospitalization benefits in patients of heart failure with reduced ejection fraction. So whether we are talking of metoprolol study, bisoprolol study, nebivolol study, or we are talking about carvedilol study, they have all shown benefits in these. So beta blockers and all-cause mortality, whatever the patient had initially, whether it was NYHA class 2 or 3 failure, there is certainly improvement. NYHA 4 also, there is similar improvement. And whether we are talking of ischemic cardiac failure or non-ischemic cardiac failure, patients are benefited by this therapy. And so therefore, beta blockers should be used. Now, nebivolol, now this study with nebivolol, senior study. Now the difference, a little difference in this was, overall population, of course, the benefits were not more pronounced, in the, whether we are talking about mortality, all-cause mortality, cardiac mortality, etc. Whereas, all these groups, other beta blockers had, like bisoprolol, metoprolol, carvedilol had shown improvement. However, nebivolol in older individuals, if you see, benefits were quite good. So because this study was done mainly in nebivolol, like average age was above 70 and there were many patients over the age of 75 years. Okay. Now one study about metoprolol in heart failure. Metoprolol, this one study, MERIT-HF trial, which was one of the first, it showed efficacy of metoprolol in moderate heart failure patients, NYHA class 2 to 4. Now significant decrease in all-cause mortality, 34%. 39% decrease in cardiovascular mortality, 49% decrease in death caused by progressive heart failure, and 35% reduction in the heart failure hospitalizations. Friends, heart failure beta blocker trials, there are so many with bisoprolol, bucindolol, carvedilol, metoprolol, nebivolol. They all have shown improvement except for this nebivolol. See, as I was telling you, no significant difference in the mortality here because, as I told you, the age group was different. So another thing is what is seen is with beta blockers only, see reduction of mortality. With bisoprolol, metoprolol, carvedilol, we see good reduction of mortality. Nebivolol a little less. Another beta blocker, zomoterol, actually mortality increased. And what is considered is, those beta blockers which have got intrinsic sympathomimetic activity, that means they also can work as sympathomimetic drugs, adrenergic drugs to some extent. There the mortality has not come down to the same extent. Whereas those who don't have that intrinsic sympathomimetic activity, there the outcomes are better. Friends, you go on adding drugs. Certainly, as we were discussing, beta blocker alone, beta blocker ACE inhibitor or AB, then if required ICD and so on, outcomes can be better, mortality can reduce. Only thing is, lastly, I must tell you, before you start, so in short, friends, my one advice to you is, in every patient of heart failure, after initial stabilization, please consider beta blockers. Just see before starting that there are no contraindications, that is absolute contraindication. If there is already severe bradycardia, you can't give beta blocker. If you have got more than first degree heart block, that is second degree heart block, third degree, certainly you cannot use. Patient who is in cardiogenic shock, there any reduction in ejection fraction, any reduction in contractility is not tolerated. Patient who is decompensated heart failure, unless you stabilize the patient, you should not start. And patient who has sixth sinus syndrome, who has got tachybrady syndrome, so on his own sometimes he's going into brady. Unless this patient has got a pacemaker, you can't start beta blocker in these patients. There are some relative contraindication, BP on the lower side. Of course, if you had to start, we'll start with a low dose, watch the response of BP, watch how that blood pressure is tolerated. History of asthma is a relative contraindication. Chronic obstructive lung disease may be a relative contraindication. And severe symptomatic peripheral vascular disease, active peripheral vascular disease becomes an contraindication for beta blocker. While starting beta blocker, whether we are starting bisoprolol, metoprolol, carvedilol, nebivolol, what dose should you start with? So this is what this particular table says, given by European Society of Cardiology. With bisoprolol, start with 1.25 milligrams. Then the increments, you can go from 1.5 to 2.5, 3.75, 5, 7.5, and 10. Ultimately, your target is 10 if the patient tolerates it. So you up to 10 milligrams you can give. And this titration gradually you do over weeks and months. Similarly, with metoprolol, starting with 12.5 or 25, gradually with increments to 25, 50, 100, 200, you can go. Our goal is to reach 200 if the patient tolerates. Carvedilol starting with 3.125 as we all do. Our goal is to reach 50, that is 25 milligram twice. And nebivolol starting with 1.25, again our goal is 10. So friends, when we do that, certainly it will be very beneficial. So beta blockers are currently the cornerstone in heart failure therapy. Up titrating to maximum dose is achieved in clinical trials that we should try and do into our patients. Bisoprolol, carvedilol, metoprolol, they are all currently approved for beta blockers in heart failure. And use of beta blockers in clinical studies has shown to reduce mortality and hospitalizations by approximately 1/3, and therefore it should be used. And with that, friends, we can certainly give better outcomes to all our heart patients. Thank you. Thank you very much. Okay, and now, so there are some questions. Alok Shah is asking me, do you prefer beta blockers in young patients with ACS? Yes, young or old, acute coronary syndrome, especially as like once the patient is stabilized, patient is not requiring any aggressive therapy, especially with diuretics, etc. Certainly, we should give, and whether they are young or old, we should give. Dr. Amit Patil is asking which other drugs help in mortality benefits apart from beta blockers. So as we were discussing, ACE inhibitors, ARBs, or these days we talk of ARNI, certainly mineralocorticoid receptor blockers like spironolactone and eplerenone, certainly that is helpful. And of course, we have to accept today now SGLT2 inhibitors also, certainly they are beneficial. Which beta blocker you prefer in COPD patients? Now, talking to my chest physician friends, Monica, what is certainly they say in COPD, not asthma, beta blockers can easily be given. Of course, they would insist that more and more cardioselective. So, of the four cardioselective, four drugs which are we use in heart failure, that is carvedilol, then metoprolol, and bisoprolol, and nebivolol. We know that if I had to talk on only about the cardioselectivity, nebivolol is the most cardioselective, and which the chest physicians even permit in presence of bronchial asthma sometimes. Whereas the other three can be given in COPD. But again, of all these, please remember that carvedilol is not cardioselective. Carvedilol, though it is a vasodilatory beta blocker, it is the beta, because it is beta and alpha blocker. Beta part is not cardioselective. So in such patients, rather than giving carvedilol, I may give either metoprolol, bisoprolol, or nebivolol. Rishikesh Patil is asking me, in patients of stable angina with left ventricular dysfunction, beta blocker is an important drug therapy. Absolutely, I fully agree with you, Rishikesh. Sapnil is saying, what is normal heart rate on beta blockers? Okay. Now, let us say that when we start beta blockers in heart failure, we will always start if the heart rate is above 70. Our goal will be to bring it below 70. If somebody comes to you already heart rate below 70, we are not likely to start beta blockers. And again, for the same reason, we are not going to start even evaporating in these patients. After giving beta blockers, how low can we brought? How low can we bring the patient? Now, this patient can, again, we would want, if the patient tolerates well, then up to 60 per minute at rest, or sometimes even up to 55 at rest will, and if tolerated well, if the patient's effort tolerance remains good and there is no fatigue and no hypotension, then we can bring up to 55 to 60 per minute. Another question by Swapnil is, how long a patient can be kept on beta blockers? Does it really cause palpitation? Now, beta blockers can be continued forever in patients of heart failure. In fact, they should be continued. We should not discontinue. And does it really cause palpitation? Beta blocker should not cause palpitation. I mean, beta blocker, because it reduces heart rate, reduces arrhythmias. So if at all people earlier having palpitation, patient should feel better. Okay. The increase in the contractility after beta blocker is not that severe that increased contractility will give a thudding sensation, and therefore palpitation is less likely. Okay, Shabaj Khan is asking, metoprolol is prior beta blocker as compared to another beta blocker in heart failure. Prior in the sense whether we should give priority, if that is the question here. I won't say priority, but well, beta blocker is one of the very good beta blockers in heart failure. Metoprolol is very good. So metoprolol, bisoprolol, carvedilol, unless there are some specific contraindications, you can use any. I am seeing only so many questions. Do you have any more? Purvi, are you seeing any more questions?
Sir, right now there are no more questions. So, shall we wait for a few minutes for
Uh,
questions?
as per your orders, I am here. So
Sir, it's up to you.
you tell me. Otherwise, if we have
Okay, we will wait for one few minutes. Okay.
okay, but then you discuss something with me.
Okay.
You,
Okay. Okay.
you tell me something about technicality of uh, beta blockers in heart failure.
Sir, I am non-clinical field. I am
Okay,
technical field.
okay, but technical means only regarding. I mean, for uh, arranging these ones. I mean, the present form of our meetings, online meetings, and what else do you have to do uh, with your technical expertise?
Sir, if there is any network issue or
Yeah,
any,
yeah, yeah.
we have to solve that issue.
So you may have I'm sure you must have used not only Zoom but all other platforms also. And which is
Yes.
your preferred platform?
Sir, my prefer platform is Zoom.
Okay,
Actually, we are using big marker platform.
okay,
It is online platform. No need to download any application.
okay, okay. I not tried that, but with some others, I'll not name them, but I had a lot of difficulties. With some, there was a lot of difficulty in sharing screen, and sometimes, having chat, etc. was very difficult in some. Whereas so far, with use of so many, this one Zoom I found to be quite good. There is
Yes,
another one which I used yesterday only, StreamYard.
StreamYard. Yes,
StreamYard was, I mean,
it is also
quite
good.
quite good, quite good. I mean, almost same as Zoom that I found, because in the last 8 9 months, almost all of us have attended and presented our talks in such meetings online, isn't it? I enjoy them. I enjoy the online meetings. In fact, let me tell you, this has really helped us a lot, especially in lockdown situation when we could not go anywhere. So many important meetings I could attend. Will you believe that some all India level conferences and even international conferences are now online, and their attendance has gone up. Uh, One of the first was the diabetes conference, 3-day conference from Chennai. You may have heard of that conference, Dr. V. Mohan's conference from Chennai. Every year, about 2 to 3,000 people attend it in Chennai, and this time he was apprehensive to have that meeting, hold that meeting at all because of the lockdown. And he thought, he was suggested by the advisors that let us have online meeting, virtual meeting. He was not very happy with that because he didn't expect so many people to attend. But ultimately, 20,000 people attended that conference. And I attended that conference. The foreign faculty was happy. All faculty members were happy. People who attended also were extremely happy. Um, and when they took feedback from all the attendees, 90% people said that next year, even if COVID situation is not there, we must have meeting like this only. It saves you so much of time. It saves you money. And you are at the comfort of your home. You of course don't have to eat outside food also, and the meetings are really successful.
Yes, sir.
Does that happen in your meetings also?
Yes, sir.
Yeah, so I think Purvi, we have waited enough.
Yes,
Should we
sir.
say bye
I
bye?
think there are no further questions. So, with your permission, shall I end the meeting?
Yeah, I think so. Thank you very much, Purvi, and thank you very much, Lupin, Stella. Thank you very much all those who attended. I am extremely grateful to you for spending this time here on Saturday evening. All the best. Keep
Yes, sir.
yourself
Thank you.
well, and I am sure we'll come out of this situation and very soon we'll meet face to face. Thank you very much.
Okay, sir. Thank you so much. So, from here, I am ending the session.
Yeah,
Okay,
thank you.
thank you so much.